So my name is Velez-Rosborough. I am a trauma and critical care fellow here at Ryder. And thank you all very much for allowing me to present. I will be discussing a case of blunt trauma. So I have no financial disclosures. And the objectives for this talk will be to evaluate the injury mechanism and the associated risk factors in a case of blunt thoracoabdominal trauma. We'll describe the options for diagnostic and treatment interventions in this type of trauma and discuss the strengths and weaknesses of the different treatment approaches. So our patient was a 27-year-old male. He was a kite surfer who fell approximately 50 feet into the ocean. That's about 4 stories. He did not lose consciousness. He was able to surface out of the water himself. And he was complaining of pain in his right chest and shortness of breath. On his primary survey, he was speaking in full sentences, so his airway was patent. He had equal bilateral breath sounds. He was hemodynamically stable. He was actually a bit hypertensive. His heart rate was in the 90s. He had palpable distal pulses in all 4 extremities, and we were able to obtain appropriate IV access. His GCS was 15. And his pupils were equal and reactive. He was fully exposed from head to toe. And on exam, really all we found was some right chest wall tenderness. And the most significant finding was that he had very pronounced orthopnea. Every time we tried to lay him flat, any flatter than about 30 degrees, he would basically panic and sit straight upright because he said he could not breathe flat. So we had to do our survey with him sitting up a little bit. We performed an extended fast, which was negative. And here you see his initial chest x-ray. So he surprisingly didn't have any major rib fractures. There's no big pneumothorax or hemothorax. He did have some mild consolidation at the right base and a little bit of blunting of the right costovertebral angle. We routinely get a blood gas in the trauma bay before we go anywhere with the patient, and his was fairly unremarkable. His base excess was +5 and his hematocrit was 46. So I'd like to pause here and open it up to the group for discussion. When you see this type of mechanism of injury, what injuries would everybody be considering at this point?
Dr. Kassim, your comment, sir?
Morning. So this is a young person who sustains an injury and hits the pool of water as opposed to concrete. Well, that carries in itself a certain degree of suspicion that he may have latent injury that you're not able to determine at that time. Luckily that he didn't show any signs of chest wall bruising, and it'll be akin to a seatbelt sign in a car injury, but he didn't have that. But he's telling you that he's not able to lie flat and he wants to sit up because he's short of breath. More than likely, he has blunt chest injury, possibly a torn diaphragm, and possibly a splenic injury, even a kidney injury on the left side. So most of the things that I would be thinking of would be on the left side. And if I have to put a central line or something like that, I would try to do that on the right side. And at the same time, I'd also look at his femur. And since he didn't land on a cement, his calcaneum may not be intact. I don't know. So those are the things that's coming to my mind.
Thank you, Dr. Kassim. I'm sorry, go ahead, please.
And also I think he's showing signs of compensation because of his youth, which I used to be one time, not anymore.
Okay, thank you, Dr. Kassim. You're younger than I am, but anyway, Dr. Varen, Ryder.
Well, if somebody's short of breath, there's either your lung ain't working or your heart ain't working. I'm going to assume that there was no evidence of a neck injury that could explain also the difficulty in breathing, assuming that there's no evidence of physical injury to the neck. I would think that this is either blunt thoracic injury. Sometimes you see the lung contusion a day or two later on the x-ray. You may not see initially, or blunt cardiac injury with a little bit of failure. So, I think that this patient is going to need both a chest CT and a transthoracic echo to find out what the cardiac function is and to be more specific into the lung function, make sure there's no diaphragmatic injury or other source of blunt injury.
Thank you, Dr. Varon. Let's go to Venezuela for Dr. Johnson. Go ahead, Dr. Johnson.
You just need to unmute your microphone, sir, please. Gary, can you unmute for him?
No, I cannot. He's muted in such a way that I can. Dr. Johnson, I'm going to come back to you, and we're going to go to Sao Paulo to Dr. Calais.
Yes, I agree with some of the comments. This patient is stable, but he has a high energy machine of trauma. So the possibility in this situation is maybe a blunt contusion, a pulmonary contusion, a cardiac contusion, and may become some wall contusions that can be some pains that can be difficult to breathing. These patients may be also, as Dr. Cassin says, maybe in these injuries, sometimes diaphragm injuries cannot see in the first X-ray. So I believe these patients need some image exams to try to explain this difficulty. But sometimes these patients have difficulty for breathing and pain on their chest. Probably he has a contusion, a pulmonary contusion, and maybe treat, and maybe not see in the first 24 hours if you only saw the X-ray. That's it.
And Dr. Johnson unmute his microphone now. Dr. Johnson from Venezuela.
Okay, I think maybe he can have is a pulmonary contusion because what Dr. Collette was saying a while. Maybe in the first 24 hours we might not see anything, but we cannot have a way of thinking that he can have spleen trauma, like a subcapsular trauma, and that is the next diagnostic what I can think in this moment.
Thank you, sir. Atlanta, Dr. Frisbee.
Can you hear me?
Yes, sir. Loud and clear. Thank you.
I appreciate all the comments. 40 feet's a pretty long way down. And I looked at the chest X-ray, didn't see a thing, but I have a sneaking suspicion we're dealing with a diaphragmatic injury. But I really appreciate the comment with regard to the bruising of the lung tissue. That won't show up immediately, but he definitely is in some extremis since he won't let you lay him down. That would tend to make me think that if he can't breathe and you don't see anything directly responsible for it on the X-ray, it may be diaphragmatic. But that's all I have.
Okay, thank you, Dr. Frisbee. Dr. Untrat, your comments, please.
Yes, so I was struck by 2 points: the orthopnea, the severe orthopnea, and the right-sided chest pain, and then also on the chest X-ray, which I presume was probably an upright film, the right hemidiaphragm seemed to be significantly elevated, especially for it's an upright, it says on the film, upright chest X-ray. A lung contusion, I think, it's not showing up on the X-ray. The contusion is not showing up, and the oxygen saturation, I believe, was normal. So and fall from that height, from 50 feet into the water, I would be concerned about a blunt solid organ injury. So in addition to possible injury to the right hemidiaphragm, disruption or solid injury to the liver. So in intrahepatic hematoma that you don't see on the FAST exam, on the EFAST. or perhaps an injury to the kidney. But that would explain the severe pain on breathing when supine and relief when he's upright. So I would try to do at first a careful look at the parenchyma of the liver with the ultrasound, and then if you can a CT scan. Maybe, I don't know if you can go 45 degrees or try to position him so he'd be comfortable enough to scan the chest and also the abdomen.
Thank you, Dr. Untrack. Philadelphia, Dr. Alice, your comments, please.
Well, this is a tricky one, but as everybody else said, deceleration injury, anything can be injured. The contusion of the lung, I would expect that would make him short of breath, whether he's supine or sitting up. And then the X-ray, if it's upright, misses whatever pathology may be revealing when the patient is laying flat, which goes along with my other colleague said about the diaphragm injury. A fall from 50 feet is pretty significant, and also you have to worry about spine injury, spinal column, the vertebral injury. Maybe that's why he cannot lay flat. But he definitely needs a good workup, and if he's not gonna tolerate laying flat, then probably I would maybe err on intubating him and just get him to the scanner to get the the questions that we have answered. That's all the comments I have now.
Yeah, we have here also Dr. Dino Altman. To everybody that doesn't know, Dr. Dino Altman has been working in car racing for 40 years, and he's currently the chief of the FIA medical committee. And I think, Dr. Altman, the kind of mechanism injury this trauma is very similar to a car crash, right? So I think your comments as specialists in sports medicine and trauma in sports can help us. What's your idea about this case, Dr. Altman?
Thank you, Antonio. Actually, I think all the previous comments have covered all the suspicions for this case, and I think it's a pretty much heavy trauma that this guy had, falling from 40 feet so high. And I would suspect and I agree that if he cannot lay down in a CT scan, he should be sedated, intubated, and CT scan should be taken.
Thank you, Dr. Altman. Dr. Hoyman, Boston?
This is a very difficult case because honestly, I didn't expect to see this chest X-ray. This chest X-ray is throwing me off. First, what I do not see, I don't see pulmonary edema, or pulmonary contusion. And pulmonary contusion, the mechanism of the dyspnea is because the alveoli fill up with blood, and which would look as very similar to the mechanism and sense is similar to pulmonary edema, and I don't see this on the chest X-ray. Diaphragmatic injury, yes, it could be, but there is no fluid in the costophrenic angle. So this is also throwing me off, although I have to say both diaphragms look kind of weird. That gastric bubble in front of the heart, it looks kind of weird, but maybe it's a bilateral diaphragmatic injury. But the thing that really caught my attention is this sense of impending doom that the patient, that was described that the patient was referring to when he was put in flat. And that usually happens when the cardiac output decreases. And that's a very, you see that in pericardial tamponades or cases like that where the cardiac output decreases and the patient has this sense of impending doom. The FAST was negative, so there is no pericardial effusion. Other things that can cause a sudden decrease in cardiac output will be a rupture, which can happen on a fall, is a rupture of a leaflet of the aorta, more rarely of the mitral valve, but that's usually associated with bad pulmonary edema that this patient doesn't have. So maybe a valve on the right side of the heart, I really don't know. This is very, very weird. If before intubating, I will probably try to get an echo and try to get a better look at the heart. Because if he has anything like that, the intubation can precipitate a cardiac arrest. And if it's nothing, yes, you have to intubate and go to the scanner. Those are the only things I can add to this case. Thank you.
Thank you, Dr. Lemon. We go to Brazil, Dr. Lima. Go ahead, Dr. Lima. Check your mic, sir. You're muted.
A minute. It's okay. Good afternoon. For us, this is a common case here in my city because it's a very favorable region with winds and attracts practitioners of this sport from the several countries. And Jericoacoara beach and Fortaleza beach is a amazing place here. In this case, for me, it's a liver injury. It's a strong possibility with impact of the ribs, cause compression and rupture injuries is a possibility. For me, it's very important attention for this case and abdominal injury. Thank you.
Thank you, Dr. Lima. Dr. Reynoso, your comments, please. You're muted, Dr. Reynoso. Check your mic, sir. Okay. We'll go to Dr. Reyes, Dr. Reynoso, and come back to you. Dr. Reyes. Okay, Dr. Reyes. Dr. Fraga in Campinas. All right. Anyone? Oh, Miss Dr. Ginsburg in Ryder. Go ahead, please. You're muted, Dr. Ginsburg.
Can you hear me now?
Yes, sir. Loud and clear. Thank you.
This is my case. So today I don't have to say much except maybe defending decisions. I'll let you guys decide what to do.
All right. Thank you, sir. Anyone else wish to comment before we return to Dr. Velez? Okay, Dr. Velez.
Okay, so I mean, you all have really astutely picked up on a lot of the little details of his presentation. So just to address some of the comments that were made, in terms of his cervical spine, there was no evidence of injury to his neck. He actually was brought in by his friends. He wasn't even brought in by ambulance. So we were able to clear his cervical spine clinically. In terms of his cardiac function, his rhythm on the EKG was a normal sinus rhythm, and he remained completely stable the entire time that he was in the trauma bay. We were slowly able to lower the head of the bed to a position where we would be able to transfer him over to the CT scanner. And by allowing us to lower his head slowly, he was able to slowly tolerate the change in position, although he still continued to complain of very severe shortness of breath as he laid flat. And since this type of mechanism of trauma is not so common except in places like Miami or in other cities where there's a lot of water sports, I figured I'd touch a little bit on the types of injuries that are commonly seen with this type of mechanism. So how, as some of you pointed out, the most common injuries that we see with this type of trauma are actually musculoskeletal injuries, most commonly lower extremity fractures. That's about 50% of the injuries in this type of patient population. And that's followed by head injuries and chest injuries. And about 50% of the patients that come in with kite surfing trauma, they're injured because they are unable to detach their kite from their harness. And that's usually because they've lost control over their kite. And that's going to be something that's going to become more common as this type of sport is becoming more common and is being practiced by people who are less experienced. Our patient was actually a professional kite surfer, which is why he was actually going so high, because he was doing a trick when he fell. And then when you're evaluating these patients in the trauma bay, there are some things to take into consideration. First, the height and the velocity that the patients are traveling at, because this is going to have a direct effect on how hard they're hitting the water and the amount of blunt force that they're taking onto their body. And then secondly, and going along with this, is how they're landing into the water. So just like we all know, a patient who lands feet first onto concrete, they're going to have a very specific constellation of injuries: calcaneal injuries, long bone injuries, spine injuries. It's the same thing when patients are landing into water. They just can come down from a higher height without necessarily sustaining the same degree of injury. Versus when patients land on their chest or abdomen, then you're looking at more of the possibility of a solid organ injury, an aortic injury, and a chest wall injury. And then the last consideration in any patient that has trauma in water is whether or not they lose consciousness, not just because of the actual injury mechanism, but because then you have to take into account whether or not the patient had a near drowning event or aspirated any of the water, which is something that has to be considered when you're evaluating and treating the patients. So for our patient, like I said, we were able to slowly lower the head of his bed. He remained clinically very stable, so we felt comfortable moving him out of the trauma bay without performing a more thorough evaluation of his heart function. And we were able to lay him flat enough with a couple of pillows that we could put him through the CT scanner. Here you see a couple of representative cuts of the CT of the chest, abdomen, and pelvis. As you can see, he had bilateral consolidations of the lung basis, worse on the right. That was pretty consistent with pulmonary contusion. Surprisingly, there were no rib fractures, not a single one. And then
Stop. Anna, go
Yes.
around the room and ask the people what they would do with this CT.
Right.
Don't tell them anymore.
With just this, these images, where would we go from there?
All right, Dr. Reynoso, your comments, please. You're muted, sir. Check your mic. All right, we'll come back to you. Dr. Altman. You're muted, Dr. Altman. There we go.
There's pulmonary contusion on the right and on the left base. I think it's one of the things that we could preview. And I'm uncomfortable here. We have the lung window, and I'm uncomfortable with the diaphragm at the right side. So we need more images, more to review all the abdomen and diaphragm, and that's it. I think also to review the vertebra. I think this is what we need next.
Thank you very much, sir. Boston, Dr. Hoyman.
I wouldn't do anything. I would just go get the other windows on the CT scan. He has pulmonary contusions. That's the only thing I can say here. There is some blunting of the costophrenic angle posteriorly on the sagittal view, which was not visible on the chest X-ray. But besides that, it had to be on the right. But that's all I can say based on this.
Thank you, sir. Dr. Navarro has a hand up. Go ahead, please. Dr. Navarro. You're still muted, Dr. Navarro. Okay, thank you.
Good afternoon. Thank you.
Go ahead, please.
I want to ask about the hypodensity in the CT, in the coronary part, in the patient hypodensity pericardial fluid like.
Okay.
It's calling my attention, that image.
Okay. Dr. Velez, did you make that out?
So the pericardial hypodensity. So that the pericardium and all the mediastinal windows were normal. He didn't have any fluid, so that was just pericardial fat. But that's a good observation.
And also Dr. Grisby has a comment here in the chat. He's talking about possible tension pneumopericardium. Okay.
Let's keep going quickly around the room.
Okay, very well. Dr. Alex, Philadelphia.
Well, I guess one question was answered with regards to that change in the density around the heart. I was curious to see if that's tamponade. I agree with Dr. Hoyman. There's definitely something happening on the right chest, lower on the axial. But with just these two images, really, I don't know. I mean, he aspirated maybe some salt water. We need to keep, to be mindful of that, and maybe be careful with type of antibiotics that will, kind of have to, consider if he develops a pneumonia, be gingerly with the fluids in terms of, blossoming pulmonary contusion. But it's kind of odd that he has no refractures and he has this contusion. So something must have happened in the belly, pushing things up in the chest or on those lines.
Thank you, Dr. Alex. Dr. Clay?
Yes, I agree with all comments. I want to see more windows in these situations, but in these situations, it's early in the trauma, so you can see in the CT, you can see the image of pulmonary contusion. In these patients, the pulmonary contusion can be evaluation in next hours and increase. So you have to control fluids for these patients and control the pain and make it comfortable for respiration. Sometimes you can make maybe cares with the airways. In these situations, in angio CT or CT in these situations, some things may happen. You can have injuries of the diaphragm, and diaphragm may be not seen in the CT, and it's very difficult to see. Maybe appear a hole in later, more specifically. And you have sometimes compressions of the chest. You can make a hole in the pericardium. So sometimes they have a contusion and have a hole in the pericardium, but the pericardium is stable. The heart is in the pericardial cavity. So it's important in this moment, there is no problem. But sometimes in this situation, when you have some compression of the chest, can be rupture of the pericardium, and sometimes there can be sometimes in these patients maybe herniation of the pericardium through the hole, herniation the heart through the hole of the pericardium, and maybe some tamponates may appear. I have some patients who have a blunt trauma with the airbag explosion and compression of the chest, and you have a pericardial rupture. And the patients comes to the OR, is stable, and sometimes they appear cardiac arrest. And you open the chest, you can see the pericardial hole and the rupture and the cardiac in outside of the pericardium, or compression of the ventriculus to the pericardial hole. That's it.
Thank you, Dr. Clay. Atlanta, Dr. Frisbee?
Oh, I don't have anything else to add. I think I'll wait. Dr. Alex's comments are pretty compelling to me, as are Hoyman's. I think I need to get some more views of this right chest, but I don't have anything further.
Thank you, sir. Dr. Untrack?
Yes, so there's pathology mostly at the right lung base, and I don't know, is that contusion or atelectasis? But whenever you have pathology at the right lung base, it's a sign of pathology on the other side of the diaphragm. It's very common in post-laparotomy patients that aren't doing well, and so I think you need to get the further images, and I would expect to see something below the right hemidiaphragm.
Thank you, Dr. Untrack. Venezuela, Dr. Johnson.
Well, I am accord with the contusion of the pulmonary contusion, but what called my attention is in the X-ray and in the CT that the right diaphragm are very high. So something is happening there. Something is happening there.
All right. Thank you, Dr. Johnson. Dr. Varon.
So the bottom line is there's a large, lung contusion there on the right side. And this is pretty early, so that's going to get really bad. So if the patient was too symptomatic, I would start CPAP just for comfort. I think that will improve his oxygenation and his shortness of breath. But definitely the only way to know is to do you need additional cuts in this CT to make sure there's no huge diaphragmatic injury. So you need obviously additional. And I still would like to see a transthoracic echo just to make sure that the cardiac contractility and everything else is fine. But definitely big lung contusion. The question is what's under that? Is that a diaphragmatic injury? And you need additional cuts on that CT scan.
Thank you, Dr. Varon. Portland, Dr. Kasim.
If I were Dr. Enrique's resident, when I saw this, first thing I would do, I will turn on the IV, because anytime you see an injury like this to the lung, the pathology there is, it is going to leak the IV fluid that you're giving him, and you're going to make it worse. So I would just shut off the IV for the time being till I make a phone call to my chief. And at the same time, I will administer oxygenation. And in fact, CPAP, it's a good idea, as Dr. Varon mentioned. And I will do everything not to make the situation any worse. Then I will ponder about what could have possibly caused this. And aspiration comes to my mind, and infradiaphragmatic pathology comes to my mind. But my main aim would be to not to make the situation any worse. Thank you.
Thank you, Dr. Kasim. Does everyone who wishes to comment, have you had an opportunity to comment before we return to Dr. Velez? Okay, back to you, Dr. Velez.
All right, so all good pickups. So seeing just lung windows, this certainly looked like either a contusion, possibly some saltwater aspiration. And then as we looked at the abdominal windows, you can see that he certainly did have some pathology below the diaphragm. He had a grade 3 liver laceration, which you can see here. He also had a small hemothorax that is seen better on these cuts, and a small perihepatic hematoma. And then when we looked a little closer at the interface between the chest and the abdomen, you can see that there is an abnormality of the right hemidiaphragm. There's definitely some bulging of the dome of the liver there, and the right hemidiaphragm is elevated. So,
Anna, obviously I came in not that day. I got involved, the next day or 2 days later, whatever it was, and you'll discuss that. But to the group, one of my fellows, I don't know if it was Anna or if it was one of the other fellows, when I looked at the CT and we saw this capping, if you take a look, if you can go back to it, you see it on the very right side and on the very right CT scan and the very left CT scan. No, the one you had that you just showed before. Can you go back to it?
This one?
No, those. If you notice, even though it looks like the diaphragm is intact, there's actually this capping. And this is why I love academic medicine, where my fellow said that she read somewhere that this is, actually, I think it was Tracy, one of our fellows, said that this is synonymous, that capping is synonymous with diaphragmatic rupture.
It's true.
Which you could see also on the previous CT, the first one that was shown. But that is synonymous, even though it may look like it's intact.
Okay, Dr. Velez, you ready for comments, or did you have more before you're ready?
So just a summary of the injuries that we found. We have the bilateral pulmonary contusions, a small right hemothorax, the grade 3 liver laceration, and then this right hemidiaphragm elevation. So with knowing what we know now and with the imaging that we have, I'd like to open it to the group to see where you all would go from here in terms of how you would treat the patient, what you would be considering in terms of his treatment course, and specifically if you're going to plan on any interventions, how you would time them, and what approach you would take to performing any intervention on this patient.
Thank you, Dr. Velez. Dr. Lima, your comment, sir. Okay, Dr. Varon.
I'm not a surgeon.
Varon's only going to give the anesthesia for the case.
That's right, but I can still tell you what I would do if I was the surgeon.
Although he does try to tell us what to do.
If you suspect this is a big diaphragm injury, I think you're going to have to go there and repair it. I don't think it's going to get okay on its own. If it was a small thing, probably you could just watch it, but I think you're going to have to go and try to fix it. I'll wait for my surgical colleagues to say what they would do and what happened to the patient.
Thank you, Dr. Varon. Dr. Kasim.
Well, I've had a case like this earlier on, many years ago, and the patient actually presented with Budd-Chiari syndrome. You know, the diaphragm was torn and half of the liver was in the chest, and caused venous outflow obstruction, and the patient came with massive ascites. So it was a very difficult repair, if I recall, years ago. And the patient needs to be resuscitated and fine-tuned and get him in optimum shape. Make sure that you don't have any other injuries that you're overlooking. Then the approach is nowadays, most surgeons probably will ignore the liver laceration and stabilize him, and then go and repair the diaphragmatic tear with a laparoscope. In olden days, we did open abdominal incision and pull the liver down and close the hole with a mesh. That's what I did in that particular case years ago. Thank you.
Thank you, Dr. Kasim. Dr. Untrak, your comments, please.
Yes, well, so I agree that you know, the liver, the diaphragm injury needs to be repaired transabdominally. I would do it open. That's the way I've always done it. But if you can do it laparoscopically, all the power to you. And then at the same time, I think you can evacuate the hematoma, you know, stop any bleeding or bile leak, leave it drain for the liver laceration, deal with that if need be, put the omentum in. But you know, if it were I would do a laparotomy. I think he's been fairly stable, and the lung pathology, the contusion won't get better as long as the diaphragm is ruptured. So I think that'll help that stabilize the same way that if you fixed a flail chest, it would help a contusion as well. So anyway, I would prefer the laparotomy, and without too much delay.
Thank you, Dr. Untrak. Atlanta, Dr. Frisbee, your comments, sir.
I agree. You know, just make sure he's stable. You optimize him, and you're gonna have to repair that diaphragm. You know, at this point, I think it's a fairly universal idea that we have to get that diaphragm back together, whatever method you want to use. Personally, I don't use the laparoscope because I'm not very good at it. So I would open them and do it by sight. Whether I used a mesh or not would depend on how shredded, how big the hole was. But that's about all I have. Thank you.
Thank you, Dr. Frisbee. Venezuela, Dr. Johnson, your comments, sir.
Well, I will go to open abdomen laparotomy, and the first thing is to try to, if anything is bleeding, to stop the bleeding. After try to, and if it has chance and the patient is stable, well, finish operating and repairing the diaphragm.
Thank you, Dr. Johnson. Dr. Altman?
Yeah, I think everyone agrees that it's a surgical approach. The discussion is between a laparoscopy or laparotomy. I think it could begin with the laparoscopy. If it's easy to repair the diaphragm and there is no other lesions that you can repair with laparoscopy, I would go for it. Otherwise, I would consider laparotomy, but would begin with the laparoscopy.
Thank you, Dr. Altman. We'll stay in Sao Paulo and go to Dr. Calais.
Yes, I agree with all comments. I believe that Dr. Altman says is to start with a laparoscopy and then go to laparotomy if it's not possible to repair, to fix to laparoscopy. Sometimes it can be not too difficult to repair in these situations because the lips of the lips of the diaphragm injuries can be very easy to fix it to laparoscopy. The question is, you can do this now or can wait. In this situation, especially is stable, you can wait and can wait some time, can see the contusion because the patient is stable, and in 2 or 3 days, you can make a laparoscopy, try to fix it. It's very difficult sometimes when you go to the emergency and do the laparoscopy, the patient is stable, sometimes to fix or to reopen the hematoma in these situations, and can be very dangerous for the patient in these situations. So you can ask if you go to the surgery at this moment or can wait. Sometimes when we have only injuries of the diaphragm, you can wait some days and put electively the patients to try to fix it by laparoscopy. If the patient is unstable, I can go to laparotomy in this moment. Thank you.
Thank you, Dr. Clay. Dr. Alex.
So to rupture the diaphragm like that is a significant energy mechanism, and I'll be concerned there may be something else injured in the abdomen. Obviously, you can wait, but I'm going to stick with the board answer, and my approach would be via laparotomy. I am concerned that insufflating with pneumoperitoneum in the setting of grade 3 liver injury and venous injury and diaphragm injury and possible lung injury may create a scenario with an air embolism. So I would just do open and repair. There was no blush on the CT scan for the liver to make me say, hey, let's go the route of IR first. And if there is no other fluid to make me concerned about bile leaking, then I would just go to the OR, laparotomy, repair, plus minus mesh, take care of the liver laceration, liver drain, and the right chest tube. Thank you.
Thank you, Dr. Alex. Dr. Oyman, Boston, your comments, sir.
So I agree with the comments that this patient, first of all, let me backtrack a little bit. The concern on repairing a diaphragmatic hernia via laparoscopy has always been the induction of a pneumothorax. I have done many on the left side and had only one case that the patient had a pneumothorax that needed the chest tube. My explanation for this, despite that being described in the literature, is that with the positive pressure ventilation, that overcomes the pressure, the positive pressure of the pneumoperitoneum. So I think many of these cases can be done laparoscopically. However, in this case, I will not do it laparoscopically or through the abdomen, mainly because I say probably because I am lazy and I like to do the things the easy way. This is much, much easier to repair through the chest. So I would probably go through the chest. I would do posterolateral thoracotomy and repair. Like the patient is not bleeding from the liver. There is nothing that worries me in the abdomen at this time. I will keep it simple, go through the chest rather than having to struggle with the liver, retract the liver, induce bleeding when I'm trying to do this, when I can probably repair everything through the chest. The only, and I will do it quickly, the only thing that to take into consideration, I will make sure that there are no other associated injuries in the chest. If the orthopnea was caused just only by this, that's great. I will just probably do it in the next few hours after the patient came to the hospital. I wouldn't wait till the next day. Because this patient most likely than not will be intubated. He was at respiratory compromise, was present on admission. So why wait? Just do it as soon as possible and get it over. But I will do it through the chest.
Thank you, Dr. Hoyman. Anyone have a comment that has not had an opportunity to comment before we return to Dr. Velez? Okay, back to you, Dr. Velez.
I'm glad we finally had somebody chime in with a thoracic approach there, because that was actually the debate within our division. So the initial attending that was involved in the care of this patient, their thought process was we would watch the patient for a couple of days, ensure that there was no bleeding from the liver, and we would address the diaphragm injury from the abdomen through a laparotomy. But then when we were discussing it amongst ourselves, the thought of actually approaching this from the chest came up. And the thought behind that was that with the liver injury being where it was, right, the dome, right where the diaphragm injury was, we would be disturbing the laceration and potentially causing some bleeding if we were to address it from the abdomen. And so what we ended up doing, first we decided to observe the patient for the first 24 hours. We did serial abdominal exams. His abdominal exam was always very benign. He had no abdominal pain really at any point. We wanted to monitor his respiratory status because we knew he had the pulmonary contusions. We wanted to make sure that that didn't get any worse. And he remained very stable from a pulmonary perspective. He never required any supplemental oxygen. On his x-ray on the following day, he did have some blossoming of the contusion at the base. And you can see that there's a little bit more blunting of the costophrenic angle, so likely a little bit more hemothorax there. And then we trended his CBCs for the liver laceration, and they remained rock stable at 14 and 40. And then after much discussion amongst ourselves, we ended up deciding to take the patient for video-assisted thoracoscopy on hospital day 2. At this point, the main reasoning behind addressing the diaphragm from the chest was, one, we were going in to do a diagnostic thoracoscopy first to verify that there was an injury. You know, the CT scan was pretty convincing, but it was a definite slam dunk, like it would have been if it had been a left-sided injury where you see the stomach or the spleen herniating up into the chest. And then our thought process was to try and repair it thoracoscopically if we were able to, but we had the plan B and C of either opening the chest or opening the abdomen if we felt that we needed to. And what we found was the 10-centimeter diaphragm laceration that extended all the way to the pericardium. He had a small hemothorax, and we could see that the liver was herniating up into the chest, and the liver laceration was right in our face. And we actually proceeded to perform our repair thoracoscopically. So we used 4 trocars, 3 12-millimeter trocars, 1 5-millimeter trocar. And we repaired the diaphragm primarily. He had a good amount of laxity in the diaphragm itself, using intracorporeal sutures, both hand sewn, and we used an endostitch device. And then we completed our case by performing an intercostal nerve block and leaving a chest tube. So here we have some images. And so at the top here, that's the most lateral extent of the laceration. At the bottom of the screen is the most medial extent. You can't see there the pericardial edge, but there's the lung at the bottom. And you can see that the dome of the liver has completely moved up into the chest, and you can see the laceration in the liver on the right there. There didn't appear to be any active bleeding from the liver. And by actually insufflating the chest a little, it allowed us to very gently push down on the liver and get it reduced right back down into the abdomen. So I actually have a little video here that Dr. Ginsburg took for us of the repair in action. So we started by repairing by placing sutures laterally and working our way medially towards the most dangerous aspect of the repair, which was close to the pericardium. And like I said, this the diaphragm leaflets actually came together quite easily once we started to reapproximate them. And there you can see that the most medial edge of the laceration is directly abutting the pericardium. And then this is the completed repair. So from lateral to medial, we were able to close it with a figure of 8 sutures. And there you can see the most medial extent abutting the pericardium. So this is what we decided to do after we debated. I'm curious to hear from you all what your thoughts are, or whether you think that this would have better been approached in a different manner.
Dr. Undrat?
Well, no, I think that, look, you convinced me. That's actually quite nicely done. And kudos to Dr. Oyman for suggesting that. But I learned something there. It's a good way to do it. When I see that next time, that's what I'm going to do, what you did.
Thank you, Dr. Undrat. Portland, Dr. Kasim? Yeah, go ahead, Dr. Kasim. You're muted.
I hate to be contrarian to a lovely lady there. I'm not very impressed that is a good repair. There's too much blood there, and your sutures may not hold in the long term. And, and every time the diaphragm moves, I'm not really convinced that this is the best repair. I think you'd have been better served going through the abdomen and repairing it through with a mesh. Excuse me if I'm being contrarian, but that's my thought anyhow. But I mean, in surgery, success speaks for itself. So what you did worked for you, and kudos to you. Thank you.
Thank you, Dr. Kasim. Boston, Dr. Oyman.
I am kind of embarrassed to suggest to do this open because you did it so well laparoscopically. I have to give you all the credit. This is a magnificent approach. I will consider seriously next time I am in the same situation because this is much less morbid than an open thoracotomy. So I am surprisingly expressing the opposite opinion of Dr. Kasim because I am in agreement with him 99% of the time. I think this is a great way of doing this, and I want to congratulate you for doing it this way.
Thank you, Dr. Oyman. Philadelphia, Dr. Alex, your comments, sir.
You can argue with success. This is great. Obviously, observing the patient for a day or two kind of ruled out any other occult problems. I had something similar when I was doing residency, but it was a stab wound with a machete through the right chest that went through the diaphragm into the liver, and we did the repair through the chest. And the patient did well, but we were worried, like, what if he's going to bleed in the abdomen while we're looking through the chest? We took that chance, and he ended up only with like 1 incision thoracotomy. Again, thanks for sharing this case. Excellent, and time will tell. Hopefully, the repair is good. Diaphragm is very well vascularized, so we're happy you presented it. Thank you.
Thank you, Dr. Alex. Venezuela, Dr. Johnson, your comments?
Well, my felicitation of the group who do this job, because over here in my country, it is very difficult to do this type of procedure because we do not count with the elements of width. But it is something new, and I am glad we learned something new what can be done, because it is not an open chest surgery, and it is I think it is a very good approach for this type of trauma.
Thank you, Dr. Johnson. Sao Paulo, Dr. Calais.
Yes. Congratulations. Very nice approach to treat this injury. I think it's very difficult to make stitches in the chest, in the diaphragm, because the ribs make it some difficult to do this. So it is congratulations to do this. It's very nice surgery. It's very beautiful. But for us here in Brazil, sometimes we prefer to do this by laparoscopy. It's more easy for us because the problem is very easy. But you can do by the chest. The diaphragm injuries, you can treat it by thorax or thoracic incision or by laparotomy. Usually, when you think there is injuries in the abdomen, you go to laparotomy usually. In this situation, you can wait and you can see there is no ball injuries, no other injuries in the abdomen. You can try to do this. I agree with the surgeries. Congratulations, very, very nice surgeries, very beautiful pictures to share with us. Thank you.
Thank you, Dr. Calais. Dr. Frisbee, your comments, sir.
Good job, nice case. It would be a task for me to do it through the chest. I'd have probably wind up opening the abdomen, doing it that way. But this is, like you said, nothing succeeds like success. So nicely done. Very well.
Thank you, Dr. Frisbee. Dr. Velez, was that the end of your comments there?
So I just had a little bit on his postoperative course.
Go ahead, please.
The main benefit to our approach was the postoperative course was really abbreviated for the patient. You know, he was able to be discharged in 4 days. He was on oral analgesics, ambulating with minimal pain by postoperative day 1. We were able to water seal his chest x-ray on post-op day 2. He with minimal output. By postoperative day 3, the chest tube was removed, and really of an abundance of caution, we wanted to observe him for one more day. So we kept him in house until post-op day 4 when he was discharged, and that's his chest x-ray prior to discharge. So I absolutely agree that the proof is in the pudding, and hopefully that our repair will hold. We felt very comfortable that our sutures were good, and that the diaphragm came together very easily, which is why we never really felt the need to consider placing a mesh. But had there been any difficulty in reapproximating the leaflets, we were prepared and had counseled the patient that there was a possibility that he would be coming out of the operating room with a laparotomy. Fortunately, he was a good candidate for this because, like you all picked up, he was very stable. He was young, so he tolerated the positioning and the single lung ventilation. And he didn't have other injuries to consider. Obviously, this is something that can only be used in a selected group of patients who are stable and who only have a select number of injuries. But were this a patient who had more complex injuries or more injuries in the abdomen, it clearly that wouldn't be the correct approach. But we found that this was a good approach for this patient who was young and athletic and wanted to get back to his life quickly without, you know, a big laparotomy or a big thoracotomy incision.
Yes, ma'am. Do we have any additional comments to Dr. Velez before I turn it over to Dr. Marttos for final comment?
I just want to say he wants to get back to his life quickly, but maybe, you know, 3, 4, 5 months before the kite surfing again.
Yes, and we did tell him that. We did tell him that he couldn't go back to kite surfing right away.
Okay, Dr. Velez, another great case. Dr. Ginsburg, thank you very much for insisting this case to be presented.
Let me make a couple of comments, Antonio.
Sure.
Okay.
Sure.
I have great respect for all of you that make comments, and they're always so right on. This is what I learned from this case since I was involved. After the first attending made the decision to wait, Anna came to me, I think it was Anna, and just said, Antonio has this case. We think they might have a diaphragmatic rupture, and we need you to staff it. And I just said, fine. We waited, I think, till the next day. I agreed with the idea, since I was covering the intensive care unit, that waiting a day without the absolute definitive diagnosis of a diaphragm rupture, to wait, and then I would take him to the OR with Anna and the team. So that was one of the points. And I was very happy to see that several of you, including Dr. Collet, who I have great respect for, said waiting a day is not a bad idea. And I agreed, in the sense of mucking around with that liver injury, you could end up making him worse in the acute phase since the patient was stable. So that's point number one. When we went to decide as to what approach, since most of my partners that came into the room said, oh, we just go through the belly, go through the belly. I talked to Anna and I said, why don't we start with thoracoscopy just to make the diagnosis? Because if you do it with thoracoscopy, you stay away from that liver injury and you make the diagnosis for sure whether it's diaphragm. And at that point, we can make a decision as to trying to fix it thoracoscopically or opening the chest. Since I'll be the first one to admit, I don't do, in fact, I don't think I've ever even thrown one stitch in thoracoscopically or laparoscopically. It's just not my bag. So once we went in, the lips for Dr. Kasim, which I respect highly, also the lips of the diaphragm, as Dr. Collet also had mentioned, were very loose. We actually did not have to push the liver back down. The lips came right up, and as Anna threw the first couple sutures thoracoscopically, they came right together very easily. Now, my patient was wearing thin at that time, because the first two sutures that were thrown took Anna approximately 45 minutes, because we're just not, we don't do this a lot. We're not minimally invasive surgeons, except for gallbladders and maybe some hernias. And when I asked if any other of my partners was very, attuned to throwing sutures quickly, thoracoscopically, no one came up with any name. So at that point, I decided, I thought, I was ready to tell Anna, that's it, I've had enough. It's going to take us 4 hours to do this. I'd rather just open the chest, and in 5 minutes we'll have it closed. We'll put 2 chest tubes. But then came a thought in my mind of calling my bariatric surgeon, Dr. Nestor de la Cruz, who's an excellent minimally invasive surgeon. And I called him and he said, I'll be there in 30 minutes. I'm in clinic. And I said, Anna, keep going. And Anna threw a couple more sutures in. And by the time he came in, I was very happy that he came in, because I'll tell you, the most dangerous part of suturing this type of diaphragm repair is where it meets the pericardium. And I really didn't want anyone who wasn't extremely savvy and extremely experienced in minimally invasive suture throwing to do that right by the heart. So Nestor came, he threw 2 sutures, left, we were away from the heart, Anna finished the operation. And it was a very nice technique. The only thing that I probably would have done differently, if we could have, was gotten the extracorporeal suture tying instrument, which we did not have intraoperatively, because then even I could have done that operation, even with my minimal experience in actually doing intra-abdominal laparoscopic suturing, because that you basically hook them and you're out and you're done. So I think it was, I thought it was a great approach type case. I think it's something that you all have seen. Now that I've been involved in one of them, I think I would approach it the same way, obviously in stable patients. Unfortunately, we don't have time. I wanted to do one other case on the approach, but we don't have time to discuss it, but maybe it's on a patient with a splenic injury, and we'll maybe bring it up as a quick 2-minute discussion with the rest of you, because I want to see what you all would do. So Anna, great case. great job that you did, and thank you very much.
Thank you very much, Dr. Ginsburg. So this is, I think this is the nicest thing about this meeting. So many good surgeons from around the globe connected here discussing the management of the patient, using the tools and the experience that they have. So I like a lot. Just remember that we're gonna have in October the Pan American Trauma Society meeting in Brazil. It's gonna happen in person. Hopefully, gonna be the first meeting, and I hope to see many of you live in person over there. And hugs gonna be allowed at that time, I hope. So I need presenters for the next few meetings. Please, anybody can present. Okay, so Dr. Johnson from Venezuela, if you have a good case, Dr. On Track. So please talk to Valeria. Alex, maybe it's your turn again. If you have a good case, talk to Valeria and let's schedule your presentation, okay? Thank you very much. See you all next week. Take care.